Hi, everyone. Welcome to our December Talks on Tuesday. My name is Lisa Terry, and I work with the Partnership for People with Disabilities as part of the professional development team. And I am going to help facilitate today's webinar along with Jeannie Schroeder, who's going to be in the background, and Jeannie is our technology specialist. And I really want to thank Michelle for taking on this topic. She's going to be our presenter today on family-centered care, the grief continuum. If you haven't already, you can go ahead and access your handouts that was provided in the registration details that were emailed to you. And I'm going to go ahead and pass it on to Michelle so she can kind of give you some background on just her expertise and her knowledge that she's bringing on this subject.
Thank you, Lisa, and thank you, Jeannie, for inviting me to be part of this Talks on Tuesday. My name's Michelle Tryon, and I've been working with children and families for over 30 years. I've provided programming in hospitals, homes, schools, and community settings. I'm a certified child life specialist, a certified positive discipline parent educator, a nationally recognized trainer and consultant for nurturing parenting programs. I co-authored a curriculum, the Nurturing Program for Parents and Their Children with Special Needs and Health Challenges. I've served as a faculty member for the National Initiative for Pediatric Palliative Care from 2003 to 2008, and coordinated all-inclusive care for children coalitions in 3 regions of New York State. And I've served on several family-centered care, palliative care, and practice committees at the Children's Hospital of the King's Daughters, which is where I'm currently employed as a community outreach coordinator and parent educator. So let's get talking about grief today. What I'd like to do is actually have you take a poll so that I have an idea of who's in the audience and what kind of experiences you are dealing with on a daily basis. So Jeannie's going to put that poll up. You're going to check off all the statements that apply to you. So I've had to support a family struggling with their child's new diagnosis. I've worked with families whose child's diagnosis was life-threatening. I've worked with families with multiple children who needed help understanding their siblings' diagnosis. I've worked with families where not all adult family members could agree on treatments or protocols. And I've experienced the death of a child with whom I've worked. You'll see those poll numbers turning blue here. So we'll give it just a couple of seconds here. All right, so now we're looking at the poll results here. I've had to support a family struggling with their child's new diagnosis. So 93% of you have had that situation. Worked with families whose child's diagnosis was life-threatening, 43%, so almost half of you. Worked with families with multiple children, so there's a sibling that's trying to understand the diagnosis, almost half of you there. Worked with families where all adult family members could not agree on treatment or protocols, so more than half there, 61%. And then experienced the death of a child with whom I've worked, and 68% of you have had that experience. So those are pretty big numbers there, and so thank you for taking the time to do that. One of the things I do want to say is this is a pretty heavy topic. So one of the things when we're going through the learning objectives is just to really be thinking about, as we have this hour together or so, that this may impact you because we have our own experiences of grief. We may be dealing with something currently with one of the families that we're working with. And so just remember really good self-care at the end of this. Take some time for reflection and some time to just take care of yourself and meet your needs. So these are our learning objectives. And of course, early intervention practice is grounded in family-centered care. You even have an IFP, which is an individualized family plan. So probably family-centered care is not new to you, but today we're going to be really focusing on that, how children and families experience grief and how we can take those family-centered care tenets to help them and support them. We also want to understand anticipatory grief and grief as typical responses when faced with a loss, and a loss can include a new diagnosis, a life-altering change, and or transition to the end of life or bereavement follow-up even. We also want to learn what parents with lived experience have to say about their needs along the continuum. And so when I say lived experience, it's actually families have given us information on what their experiences have been like and how we can be helpful. So what better way to look at family-centered care than to ask families themselves? So we want to know what they say their needs are. So, and we want to help them cope and hope, not just cope, but really to get that hope in there as well. So let's take a look at this slide here, family-centered care. So I'm going to read a quote here. Copernicus came along and made a startling reversal. He put the sun in the center of the universe rather than the earth. Let's pause to consider what would happen if we had a Copernican revolution in the field of disability. The family is the center of the universe, and the service delivery system is one of the many planets revolving around it. Such a revolution leads us to a new set of assumptions and a new vista of options for service. So family-centered care is not a new concept. This quote was actually from 1985, but it is an evolving concept. And early interventionists, like I mentioned, are likely familiar with family-centered care because it's the foundation of your work. And we know that children exist within families. So delivery service models can often be identified as system-centered, family-allied, family-focused, or family-centered. And if it's truly family-centered, the system revolves around the needs of the family. So if we think about it really simply, it's whether we're doing things to families, we're doing things for families, or we're doing things with families. And so we don't want to do things to children and families, and we don't even want to do things for children and families if they're capable of doing them for themselves. We want to be doing things with families and letting families take the lead. So it's an evolution in the way of thinking, but let's take a look at what it looks like in practice. All right. So these are a couple of the tenets of child and family-centered healthcare. So the family as constant, the role and importance of the healthcare, home care, social service systems vary, and the people staffing them change. So the family has the history and the inside information. Even when they're not together, they work as a system. So if there's a divorce or a deployment or the child is hospitalized, they're still impacted by the roles and rules in their family. Every family member influences the system. So we also want to consider, aunts and uncles and grandparents and how they influence the system as well. And every family has strengths, every family. So when we come from a strength-based model, we recognize that each individual, including each child, brings something different to the table. What are their coping strategies? What are their values, religious or cultural values? How do we help them build on their strengths? So we want to do it from a strength-based model. What are they doing well, and how can we help them to cope? And then we have information sharing with family members and the child as appropriate. Certainly in the case of working with the 0 to 3 population, we're not going to be sharing information with the child, but when we're working with older children, we should be. So information sharing means we're giving them unbiased, timely, complete, responsive, and understandable information. One of the participants interviewed for the Initiative for Pediatric Palliative Care made this remark. He said, just because I don't speak well, it doesn't mean I can't understand your doctor talk if you break it down for me. So we want to give families complete information. It's the opposite of what we might call mutual pretense or the conspiracy of silence, where healthcare providers avoid those difficult conversations, and sometimes parents avoid those difficult conversations as well. We want to really be giving them all of the information that we have. We don't determine what a family can and cannot handle. If we have information that's unknown to them, we need to share that with them. We shouldn't dole out information a little bit at a time thinking we know what's best for them. They need all of the information to make informed decisions. And if they don't understand the information, we need to present it in a way that they can understand it, and we need to repeat it as many times as they need to hear it. There's actually a picture in this book. The book is called Arms Full of Time. And it was drawn by a 10-year-old boy. And he was told that he had cancer. And so the picture is him, and then he's got this thought bubble above his head. And in the thought bubble it says, "How long do I have, Doc?" And so in talking with that boy, the child life specialist that was talking with that boy asked him about the picture. And he said, I didn't want to ask the question because I wasn't sure I wanted to hear the answer. But he also did not hear anything that was said about his protocol for treatment, and that he actually had a very good prognosis. So families can take in just so much information. We may have to repeat information if they weren't able to absorb it when we first said it. So we really also want to be looking at collaboration and sustainable care processes and systems and policies. And those two go kind of hand in hand. So that's really that doing with. What are we doing with families? We're helping them create goals and care planning as if we're collaborating with them, but also we're doing at higher levels where there's policies and procedures, we need input from families who have that lived experience. So we're hearing about parents' experience and how we could create or change systems and relationships so we can be more responsive to their needs, rather than trying to make them fit our models. We can go to the next slide, please. So the last two here are family-to-family communication and child-to-child communication. And again, because you're working with those younger children, it's not likely that this would be as important. However, they may have siblings. And so if the siblings could be involved in something like a sib shop, so that they know they're not the only one who has a brother or sister who has some challenges. And then family-to-family communication. So really assisting families to develop support groups or peer counseling, any kind of lines of family-to-family communication. I know at CHKD we have a program called Care Connection, and they have parent liaisons who have lived experience and now are helping other families kind of work through the systems. Or the Tidewater Autism Society is another great example. So it's parents who've actually walked the walk are now helping parents who are new to the walk to come in and to be able to navigate successfully. All right, so this is a quote from Speaking Their Language, and it's from IPSE, the Initiative for Pediatric Palliative Care. So this was an interview with a 25-year-old nurse whose younger sister was diagnosed and treated for a fatal brain tumor over the course of several years while they were growing up. So now she's grown up and she's a nurse, and this is what she has to say. From a healthcare perspective, you need to go in there waiting to see what they bring to you and not bringing what you have. Seeing what the family makeup is and seeing the different roles people have in the family, and then supporting them any way that you can, versus bringing your structure into their home, because it doesn't tend to work very well. And then we have a second quote, and this one is actually from Child Life Focus, so the Association for Child Life Professionals. People are like animals. They have different attributes. My husband was like a bear protecting his cub. It is just what a parent needs to do sometimes. I was an ostrich, but eventually came up for air. Just hang in there with me. I need your help. So families are unique, individuals are unique. Hearing what families have to say and their perception of what's going on. There's a couple different ways that people can cope. Some people are assimilators and some people are avoiders. And so assimilators really want to take everything in. They want to know all the information. They want to be hands-on. And avoiders are just the opposite of that. You know, maybe they're not ready. And so I was thinking of, when I read this, a couple that I worked with. So I was in the pediatric intensive care unit. And there was a child who was getting ready for discharge. And so the mom was an assimilator. She wanted to learn all the nursing care. She wanted to do, even while they were hospitalized, do all the tasks of daily living. She attended every therapy session with her child. She just couldn't wait to get the child home. So she had a level of acceptance that, you know, I'm ready to take this on. My concern for her was that she wouldn't ask for help and that she would think she had to do everything herself and then get exhausted. But that was her journey, and that was her choice to learn everything. That would be an assimilator. Dad, on the other hand, was just the opposite. He didn't want to learn any of it. He didn't want to know any of it at this time. So it's okay. Whichever way people need to take information in and absorb it and deal with it. One of the things, thinking of when you're working in early intervention, you can sometimes get caught in the middle. So mom's taking everything on and maybe discloses to you that she's frustrated with dad. Those things happen. But all families have strengths, so we really want to build on their strengths. And we want to really think about ways that we can help them communicate with each other as well, because that's important for the child. Let's go to the next slide. So this is a picture of the 5 stages of grief. So I'm sure we're all familiar, or most of us are familiar with Elizabeth Kubler-Ross stages of grief. And this picture portrays how messy those stages can be. The individuals may go through many rounds of grief. They might skip a few, backtrack. Family members might be in very different places at different times. And the main thing for providers to do is just to be present to wherever they are and not take it personal. If they're going through an anger stage, it's not about you. It's something that they're going through or processing. So we want to be present with them. We want to allow them space they need to experience their grief, whatever that looks like for them. We also don't want to be comparing families. And this is a hard one. We may be working with a family or have a family on our caseload that is struggling with really complex medical needs for their child, and you just don't know how they're getting through the day. And then we have a family that's challenged by something, but it seems less daunting to us because we are actually aware of all these other families with very complex needs. But for that family who has less daunting needs, they may need more support in developing coping than a family with complex needs. So there's no, no discernment in what is or isn't an experience of loss or grief for a family. It's their discerning what is or isn't a loss for them. We've got to meet families where they are and support their adjustment. I recently met a couple whose 7-month-old nephew has a degenerative disorder, and he has a life expectancy of about 2 to 4 years. So they had come to me and wanted to know how they could talk to their children, who are the cousins of this child, and the cousins are like 7 and 9 years old. And so I was thinking about these stages of grief and also thinking about the assimilator and the avoider in this particular situation. Mom was very open. She shared all of her concerns and fears. She was being very vigilant to make sure that her children didn't have any signs or symptoms that they weren't coping well. So she was on it. Probably even a little bit too much on it, like just looking for things, right? And Dad was kind of still in denial. He kept saying things like, well, I'm sure they could find a cure if they just go to a bigger hospital. Are we sure that, that he's going to die? So it was really, for them kind of coming to terms in their own way with how we're going to deal with this grief and how we are going to help our children cope with the grief as well. So we take one day at a time, help them learn to listen to each other, normalize whatever it is that they're feeling, and validate for them whatever it is that they're feeling and wherever they are in this messy stages of grief. And we can go to the next slide. So this is where we're going to have you communicate and chat. So we want you to share your responses in the chat box. So what is grief? When you hear grief, what comes to your mind? So just go ahead and type it in there. Give you a couple of minutes to think about that. Sorrow, longing, sadness, sadness over loss, death, a process, confusion, responding to an unfortunate event, depression. So it comes up in different ways for different people. For some, it's sorrow, sadness, anger. You have to work through it. You can't really avoid it. All right, so keep typing some things in if you'd like. Lost expectations, that's an important one. So not just the loss itself, but the expectation of what could have been. So let's take a look at this slide. And you also have a handout that looks exactly like this. So what is grief? So grief is not the event or the situation itself. Loss is the event or the situation. For example, when a parent hears the news that their child has autism or a genetic disorder or cancer or a developmental delay, they experience a loss. Grief and anticipatory grief are the reaction to the loss. So when we have anticipatory grief, it's anticipating, looking to the future, like someone here said, lost expectations. We're thinking about what might happen. It can be experienced like a series of losses. What milestones will my child miss? What suffering will my child experience? What sacrifices will we have to make as a family? How can I handle this? This wasn't what I expected. This wasn't what I had planned. It can be anticipating even the illness, progression, and anticipation of death. So anticipatory grief. And then we have grief, which is the reaction in the moment to the event, which is the loss. So with grief, there's so many things that happen physically and emotionally. And these thoughts and feelings really in no way decrease the parent's love for that child. Even if we're thinking about, I didn't expect this diagnosis. But there will be an adjustment period. And there's no real time frame to it. The process of adapting is called mourning. So that's the process of adapting to the loss. Oftentimes we think of mourning when there's a death, and so that came up over on our chat box here. However, mourning what might have been and adapting to what is a process in itself. So if we want to think about bereaved parents are parents whose child has died, but also parents who had an idea of who their child could be and what their amazing future would have looked like if they hadn't been diagnosed. They experience a sense of loss and react with grief and can be actively mourning even when their child is living. It's not language that the general population would use, but it helps us as healthcare providers to consider the experience of every family we work with who is touched by their child's disability or diagnosis. And when I say touched by, it's, I like to think of that as being made vulnerable. So I am vulnerable because this has happened and there was uncertainty and I'm not sure, what to do. So I am vulnerable and I'm seeking help and I'm working through this process. So it helps us gain empathy and understanding of the families that we work with. And we need to be aware that active mourning can happen anywhere along that continuum. So here's another chance for you to type into the chat box. What do families need when they are experiencing loss and grief? Support, time to heal, hope, really important, one of my favorite words, hope. So we want them to cope, but we also want them to hope. Someone just to listen is coming up several times. An opportunity to share their grief. So it lessens the grief when they're able to share it. It's not as overwhelming. They need empathy so we can understand what it would be like from their point of view. Not that we can ever really understand, but we can empathize with them. Space, so space to feel. Allowing themselves to feel all their feelings. And individuality, so there's no one answer to any of this. Resilience, so the ability to handle really hard things and be okay. All right, so again, keep typing some things in if you'd like, but we're going to move to the next slide. So those are just really some really powerful answers there. So let's think about this from a particular family. You have been working with Shen. He's 2.5 years old, and you've been working with his family for several months. You just received a phone call saying that the child has died. Shen had neuroblastoma, an aggressive cancer in his case, and had been receiving treatment. Shen was hospitalized many times, but always seemed to rally. The parents are obviously devastated. Although the type of cancer had a very poor prognosis, his family feels like the death was premature and unexpected. So they really wanted more time. So when we think about what are the losses for this family, of course, there's the physical loss of a child who's no longer with them physically. There's the emotional loss of ever hoping for a different outcome. So that kind of loss of hope. There's loss of future, loss of time. Even sometimes loss of healthcare team members that they had come to count on and had been working with. And then we think about, was this loss anticipated? Well, I guess to some degree it was, but this is more permanent. You know, they knew it was a poor prognosis, but it was unexpected as they had been to the hospital probably many times before. And Shen had rallied, you know, he returned home and, you know, they just kept going. So it was an unexpected, they didn't think this would be the time. And so when we think about, for this particular family, what might the parents need physically and emotionally at this moment? So go ahead and keep typing in that chat box. What might the parents need physically and emotionally at this moment? And while I'm, all right, they need assistance in the day-to-day, they need to cry, they might need counseling, they need food, they need sleep, they need connection, someone to talk to, someone to listen to, a hug, a very simple gesture of connection, a way to symbolically mark and remember the time they did have with their child, resources. So the very practical day-to-day things, as well as the presence of someone who truly cares. And a way to honor their child and who their child was and is. All right, let's move to the next slide. So again, keep typing in if you'd like to. I think the communication, the chat box is really on fire over here. You guys have some wonderful insight. So this slide here looks at the work of Javier Kane. He's a pediatric oncologist who started in San Antonio at a children's hospital and then moved to St. Jude's. And he's been very involved in the enhancement of pediatric palliative care. So he suggests that we often in the medical system ignore the whole child and just focus on the treatment, right? And we ignore the family and just focus on the treatment. So kind of the idea is that families can find peace regardless of the outcome if they have these three components in place. If they can find meaning, if they have competency, and if they have support. So even if the child dies, they'll be at peace if they have these three components. So let's look a little bit at these. So meaning, you know, how do they make sense of this? Is there some lesson to be learned? Is there some connection that they have to a religious or cultural belief that helps them deal with suffering and pain? You know, I worked with a mom one time. She had a child with severe disabilities, and she said to me, we appreciate so much every day we have with her. I've never felt so much gratitude for the small things in life. And that was her way of finding meaning, that she was finding gratitude even though she was in the intensive care unit with her child. It also could be helping other families who are experiencing similar challenges. So once I've kind of gone through this, I can help other families because I have a blueprint maybe for it, remembering that all families are individual, but I have that sense of camaraderie. And then there's competency. So this kind of goes back to that family care element where we say that they need information. So if families have all the information that they need to make informed choices or informed decisions, they can feel very competent in making those decisions. There's not a lot of second guessing. They can care for their child with confidence and they're able to keep them comfortable. So if they are taking on some of the nursing role, you know, and some parents want to do that and others don't. You know, I had one mom that said to me, I don't want to be my child's nurse. I want to be my child's mother. And then I had another mom say, I prefer to do everything myself. You know, I don't want anybody else doing anything. So, you know, really thinking about it, they're a full partner in the way that they want to be a full partner, whatever fits best for them. And they have the information that they need to make choices. And then support is the last one. So support can be an ongoing formal, like in early intervention, you're there with them in a formal capacity, or it can be informal. Do they have neighbors, friends, family members that are helpful to them? So it's someone who has their back and can be objective and non-judgmental. So as I am going through this and I'm making decisions, that you're going to listen to me, you're going to support me in the decisions that I'm making, you're going to let me, just sound off to you. You're going to be like a sounding board without giving me advice, without trying to talk me into something, without trying to happy me up. And they're going to be there in a very real way with those day-to-day needs, bringing over a meal or taking you to the doctors with your child. So those support systems are really important. So meaning, competency, and support. So, giving you lots of information today. This really looks at some of the newer models in grief. So we had those 5 stages, and with the 5 stages that we looked at, there's almost an idea that you have to get through them and then the grief will be resolved. So you'll get to acceptance. This is really looking more at not that disengagement or that resolution, but looking at those continuing bonds. So the process does not end. The ultimate goal is not resolution. Bereavement affects the mourner in different ways for the rest of their life. People do not get over the experience, rather they are changed by it. Part of the change is a transformed but continuing relationship with the deceased. So if we're looking at that continuing relationship, what does it look like for parents, right? So they talk to their child. They say, oh, my child would have loved this or would have loved that. They talk about things that they did with their child. They have memories. They do some of those memorials and honorings that keep their child alive, their memory alive. It could be even at the holiday that they have a certain ornament or something they put out that is a memory of that child. So life goes on and my child's memory is a part of me. So there's a relationship with a flow to it and a freedom to it. It's different than getting stuck in grief and thinking, this never should have happened. It's really a way of acceptance, but it's also a way of continuing the bond with the child and knowing that your life has changed. You've been transformed by the relationship that you had with that child, however brief it was or however long it was. So what are some do's and don'ts when communicating with the bereaved? So for this one, I really want us to be thinking about bereaved parents at all stages of the journey. So not just the death of a child, but when there's a new diagnosis or there's a recurring disease or there's deteriorating health. Each time they go to the hospital, they don't rally quite as far back. Or they're at end of life, transitioning to end of life, or even their spend in death. But really think about that whole continuum and go ahead and type in the chat box. What do you think are some do's and don'ts when communicating with the bereaved? Don't assume. Do listen. Do attend. Don't tell them how they should feel. Don't put a silver lining on everything. Don't ever say, I know how you feel. Don't say they're in a better place. You still have other children. Don't cut them off. Give them space. Meet them where they are. Don't expect them to react the way you think they should react. Listen more. Talk less. Be willing to interact. Don't ignore the situation. That's a really important one. So be there, be present, even if it's uncomfortable for you. Sometimes just being in silence with them. Let them cry. Use their child's name. Ask them what you can do to help. Let them know that their child's life mattered. Wonderful. All right, let's go to the next slide. You guys really have a handle on this. All right, so communicating with the bereaved, you also have a handout that you can take a look at. So these are a lot of the things that you came up with. Don't advise. You should get out more, stop feeling sorry for yourself. Why don't you just, fill in the blank? Don't try to happy them up. Now, don't cry. Where's the optimism you always have, that silver lining? Don't assume. It's better now, at least she's at peace, or I know how you feel. Don't reassure. God never gives us more than we can handle. Don't worry, it'll be fine. Don't argue. How can you say that? It's wrong to blame everyone. Don't minimize. It could always be worse. You're young. You can always have another baby. Someone mentioned, well, at least you have other children. Do ask non-judgmental questions. What are your thoughts about? Do validate and empathize. You have a right to feel however you feel about that. You've been through a lot. Do support. I'm here if you want to talk. I'll sit here in silence with you if that's what you need. Do clarify. So when we're clarifying, we're saying, I'm not sure I understand, tell me more. We do give information or explanations that could be helpful. Generally, that medication is used for infant-child CPR is offered at. And use a lot of feeling-focused statements. You are still feeling the disappointment. Tell me more about how you're feeling. Kind of going back to what are your thoughts? What are your thoughts? What are you feeling? Let me be here and listen to that. All right, so now we're going to have you go to the next slide. Like I said, keep typing in that chat box if more things come to mind. So this is a situation vignette. Monty and Abigail have been receiving services for their daughter, Ari, since she was 12 months old. Her parents have been concerned about her communication, but Ari is now 25 months old and the parents just received an unexpected diagnosis of autism. I'm probably pretty critical there, the word unexpected diagnosis. So that's the situation, and we're going to go to the next slide, and I would like you to try and use your stamp now. So we practiced that, or some of you did. So again, you're going to go to the top of your screen. You're going to click on View Options, Annotate, and you'll see the toolbar. Find the stamp. The stamp tool is in the red box on the whiteboard example. I know some of you had to use the draw if you couldn't use the stamp. But you hover your mouse over stamp and click to open a box, and it'll give you stamp options. And then you're going to bring them down and just click on the whiteboard to drop your stamps. So I see some of you are getting it. So this is what is not helpful. What is not helpful? I still see a few popping up here. All right, and when you're done stamping, make sure that you click out of Annotate and Stamp so that you don't start dropping stamps when you don't mean to. All right. So let's go to the next slide. We'll take a look at this. Now we'll go to the next slide. And we'll see what is helpful. So the ones that were not helpful, where you need to be strong for your family. I know how you feel. It must be a test of faith. At least your 5-year-old is normal, and don't worry, your child will outgrow the situation. These are things that are helpful. You seem confused and angry, and then they can clarify that. If you say you seem confused and angry and they're saying, no, I'm sad and disappointed, then you can validate that. I'll be here if you need to talk. You're going through a lot. How are you doing? Can I be of any help? Which of your family members and friends can you count on? So trying to really think about who are their informal support systems and just being there. And that question really, can I be of any help? What can I do to be helpful? All right. Great job with that. So I mentioned in the very beginning of the presentation that self-care is really important. So when we are working with families, so somebody's dropping little stamps right now, you want to click out of your Annotate. But it's nice that it's a heart. We know that we're loved, right? So one of the things that's really to be important, important is to take care of ourselves. So this quote actually comes from Parker Palmer. And he says, in professional training, we often learn about the world as though it is a world that we do not inhabit. So we are impacted by being in relationship with families at some of the most challenging times of their lives. And we have our own grief journeys. They influence our interactions, even when we're trying not to let that happen. So this second one, the doctors and nurses who allow themselves to show their genuine emotions help me the most. When we really think about what it means to be genuine or be authentic with families, we would think that means to share some of our vulnerability. But many times when we're trained to have professional boundaries, which is a good thing. But what does that actually mean, to have professional boundaries? If we can be genuine with a family, we can care genuinely about them and their children. There's in fact some research that's shown nurses who are more involved with their patients rather than trying to keep a distance had less burnout. It seemed the deep caring in the relationship offered a source of energy and sustenance that reduced burnout. And they did clarify in the research that the involvement was based in clear professional ethics and skillful handling of relationships, but also finding meaning in their work. So caring deeply was their calling. So when we think about how involved we get with families, especially if you're going into the homes of these families, you're very involved in their lives. That trying to keep a distance can sometimes take a lot of emotional energy. Of course, we want to let them know that we genuinely care about them and their children. And we also want to step back and make sure that we have informal and formal support systems for ourselves so that we're not bringing our grief to them. So I'd like you just to do a little homework. Due to the length of the webinar, I'm not going to have you do this reflection right now. But I'd like you to kind of think about these questions. What kind of emotional energy does it take to keep a distance? And can we have a foot in both worlds? Can we be with them in their world and then step out of their home and be in our world without taking that with us? And what do we need to do for self-care so that we can set up healthy boundaries for ourselves? All right, let's go to the next slide. So just do some thinking on that one. And really what I'd like to end with, before we get into some questions, if you have questions, is this poem. It was written by a father whose daughter lived for 7 months with Petty syndrome. So he participated in an initiative for pediatric palliative care retreat at UVA. So we were together in the fall of 2008. And then when we all left the retreat, he sent this poem, and he's given me permission to read it. So the name of it is Surf. For those who care for children and families. Mine was a swamp I had to traverse. I am still wiping the mud from my eyes. But you do this every day, and then you have to go home and eat your dinner. It must come on you like waves, lapping, tumbling, crashing, never resting. And so maybe you are one of the rocky ones, hardened against the breaking water, protecting your shape, preserving the mainland. Or are you the sandier shore? Do you allow the waves to change you? Here is something I believe about you. No matter how you bear the surf, there must be a place in you where a little water collects. I wonder, have you ever, when the tide is low, gone there and taken notice of how beautiful that pool can be? Perhaps sometime we could go walking together, exploring the crevices or scanning the sand, stooping to retrieve those curious and delicate treasures the waves have brought. So let's go to the question slide. Don't want to move too quickly away from that. It's such a powerful poem. So questions. Here's my contact information. This is what I look like when I'm in a picture form. If you have questions, you can go ahead and type them into the chat box. I think you also may be able to raise your hand and we could unmute you.
Thanks, Michelle. And while people are typing in some questions, I know that's a lot of powerful information for such a heavy topic. So we really wanted to make sure that we give you time to kind of debrief and ask questions and reflect as needed. So I really want to thank you, Michelle, for really supporting early interventionists in this topic. But just some information while you're typing. I do want to let you know that you will receive a survey following the webinar, and also to go ahead and save the date. We're going to take a break from our Talks on Tuesdays in January, but our February 4th and our March 3rd Talks on Tuesday topic will be about working with fathers and supporting them. So go ahead and save those dates, and I'm going to go ahead, Michelle, and let you start answering questions.
Yeah. So this one's more of a comment, and I think it's a very powerful comment. One child's loss of life cannot replace another child's presence. Thus, the children that may be left behind cannot take away or replace the grief you experience. So definitely those not to do is to say, well, at least you have other children. And for families, you know, sometimes that's what forces them to get out of bed in the morning, is there are other children that they need to take care of. However, it doesn't replace their child. And having a child subsequently, you know, if you give birth to another child, it does not replace the loss and the grief experience. You still have a very separate individual relationship with the child who has passed. So looks like Jeannie's putting up the resources here, and so you'll also get that in your link. Someone had asked, you know, do you have some resources here? One of the books, I think it's on here. I'm not sure if it's on here, but there's a book called Shelter from the Storm. And there's several books, if you go on Amazon, called Shelter from the Storm. So you want to make sure you get Shelter from the Storm, something like experiencing a child experienced a life-threatening illness, so that you don't get, there we go. Thank you, Jeannie. Shelter from the Storm, Caring for a Child with a Life-Threatening Condition. It's a guidebook for parents navigating complex journey with a seriously ill child. So this goes from the time of diagnosis and gives several different scenarios. It's a really helpful book. And here's one, someone suggesting How to Say Goodbye by Ted Menton is being added to our resource list. What is a great resource for service providers who have experienced the loss of children on their caseloads? So one of the things that I hear a lot of people say who are in healthcare is that it's not my child. So there's this tendency to think that you don't have as much right to experience grief as the parents. And obviously it's a different level of grief, but you have a right to experience grief. So I don't know exactly, I can't think of a book in particular, but you can look at the Association for Child Life Professionals. There's some grief resources on there. And just to really be thinking about, in general, experiencing grief. So journaling, taking time for self-care, meditation, if that's your thing, yoga, walking on the beach. What book would you recommend for a classmate whose classmate dies? Use it as a read aloud. So again, there's the Centering Corporation, which is one of the resources there, has a lot of books that talk about children and how they experience grief. And and I don't know the age of the child that you're thinking about. However, there's one about teen grief, and there's a couple of them that say when something terrible has happened. And so if there's a tragedy and they're trying to make sense of it, it's more of a workbook. Book for children for impending death of a parent. There's one by Kathleen McEwen, and it's on the Child Life Association website. I think it's How Do We Tell the Children? Just thinking this off the top of my head, but I can send the name of it to Lisa to send out. There's also one that's called A Tiny Boat at Sea. And it talks about if you're helping children who are going to be experiencing the death of a parent, and it gives some guidelines, which are thinking, feeling, growing, and doing. So what is the child thinking about what's happening? What information do they need? And then how are they feeling about what's happening? And we want to validate that feeling. And then the last part of that is growing and doing. That children have a very strong desire to be okay. So what can they do to help themselves feel better when they're ready to feel better? There we go, tiny boat at sea. All right, so the chat was filling up pretty quick. I'm not sure if I got to everything. Did I miss anything?
I think you got everything. Megan just wanted to say thank you for this training because she hasn't been in the field long, but it's really helpful because she's had a family experience loss that's been publicized in the news, and that's been really hard for them. So this information's been very helpful. Right. For her. So again, Michelle, just thank you so much for covering this topic. This is a really hard topic, and it's funny because I've heard it for our practice sessions a couple of times, but it actually hit me a lot harder today listening to it again. So please, I do hope everyone does practice some of that self-care after you end this session today. And again, feel free to reach out to Michelle if you have any questions. Her email address is on the screen. And this session will also be archived if anyone needs any, wants to share this with any other coworkers or colleagues. So thank you so much.
Yeah, well, thank you. Thank you for inviting me and for giving me the opportunity to share this information. I think it's really important.
Does the archive, I see a question, does the archive also include the chat? And yes, it should include the chat as well. Thank you, Jeannie. Jeannie posted the website where the archive will be available.
So this is one too. If someone's a grieving parent, they really share your personal loss of work. If it will help another family, I've done so. So I think that's really important there. Really think discerning whether this is something that should be shared or are you doing it for your own, to make yourself feel better, or is it something that truly could be helpful for the families? And that's an individual call, depending on the family that you're working with. So certificates of completion after taking the survey.
Yes, so once you complete the survey, you will receive, Linda, a certificate. So Jeannie will go ahead and send out the certificate of completion shortly, and so look for that in your inbox and go ahead and complete that and let us know if you have any other questions or issues. And thank you again so much for your participation in our December Talks on Tuesday. And Michelle, thank you so much for covering this topic for us.
Thank you.